The one study that any trainee should know and should read in the area of red blood cell transfusion is the TRIPICU study.
Welcome back to PedsCrit. I'm Zach Hodges, a pediatric intensivist at the University of Texas Southwestern in Dallas.
And I am Alice Shinkley, a pediatric intensivist at Cohen Children's Medical Center in New York.
And we are so excited to be sitting down with two guests today to discuss red blood cell transfusion and critical illness. First, I want to introduce a co-host on today's episode, Dr. Kailey Remien. Kailey, please introduce yourself.
Thank you for having me. I'm Kailey. I'm currently a pediatric critical care fellow at Nationwide Children's Hospital. I'm interested in data science and informatics and geospatial analysis. And right now I'm working on bronchiolitis and health equity.
Ooh, neat. Geospatial. We like it. All right. And we would like to thank you for recruiting Dr. Jen Muszynski today to really talk about when to give red blood cells in critical illness. Dr. Muszynski, can you tell everyone who you are?
Absolutely. I'm Jen Muszynski. I'm one of the pediatric intensivists at Nationwide Children's Hospital. I'm also a clinician scientist. I'm a PI in our Center for Clinical and Translational Research and have been thinking about this question of when to give red blood cells to critically ill children for nearly 2 decades now. And really excited to share with y'all some of the things that we think about and what we've been learning.
Excellent. Excited to dive into this. Before we get going, any conflicts of interest to disclose? Kailey, perhaps for you first.
I have none.
And then Jen.
I do have NIH funding related to some of the things we may talk about, but no other financial conflicts of interest.
Sounds great. Kailey, how about I give you the floor if you'll give us our first question.
One of the first formulas that each critical care fellow is reminded of in training is the one for oxygen content in the blood. In almost all clinical scenarios, oxygen bound to hemoglobin far exceeds dissolved oxygen. And as a first-year fellow, I remember learning about how biochemically it's so important to maintain a robust hemoglobin concentration to ensure adequate oxygen delivery. But at the same time, we tolerate quite a bit of anemia in the PICU, see many patients recover from critical illness with perhaps even up to like 50% reduction in their hemoglobin and oxygen carrying capacity. And just want to explore that a little bit more today. So to get things started, what do we know about rates of anemia in the PICU?
It's really interesting that you frame the discussion that way, because I often start when I'm talking to trainees, as you know, with this reflection that as intensivists, what we do for a living is optimize oxygen delivery. If you think about most everything that we do in the ICU, whether it's getting oxygen into the body, getting oxygen to flow around the body, it's trying to match oxygen delivery to oxygen demand. That's what we do. And you're right, we teach you, and you learned in medical school, that the most efficient way to augment the amount of oxygen in the bloodstream is by increasing the hemoglobin. That's how the math works. And so it does bring up this contradiction of why is it that we don't transfuse everyone to a normal hemoglobin or even a supranormal hemoglobin? And in fact, historically speaking, the paradigm was that you should maintain a normal hemoglobin in the face of critical illness because you're trying to augment oxygen delivery. When in reality, it is quite common for patients to be anemic in the ICU, and much of the time that anemia is quite well tolerated. So your question about how often does anemia happen in the ICU, it's quite frequently. It depends a little bit on how you define anemia, though. Because if you define anemia as a slight reduction, say, a hemoglobin of 10 rather than 12 grams per deciliter, then it's very, very common. The rates of more severe anemia, probably a little bit less common. If we're talking in the range of below 8 grams per deciliter, the numbers are a little bit smaller, but still not infrequent. As you know, we see it in the ICU quite a lot.
Oh. Why is this? Is there, when you look at these numbers, especially you're looking at the databases, are you like, oh, classic PICU, we're taking too much blood out of the patient?
Well, that's one of the items for sure. And in fact, there have been a few published quality improvement initiatives aimed just at that, at looking at the sheer volume of blood that is taken for lab studies. And can you minimize that by use of microtainers instead of the full blood collection tubes, by batching your labs, by thinking about those routine labs that we just reflexively get, do we actually need them? And so as part of a comprehensive blood conservation package, that really is a significant portion, particularly for the neonates. And if we think about some of our sickest neonates, the Bates study from the Capricorn Network, they actually documented a fair proportion of red cell transfusions that were perceived to have been given in part due to blood loss from laboratory draws. So that definitely is part of it, but that's not the only part of the equation. So there are lots of different reasons why a patient in the ICU would be anemic. One is their illness in general, right? Many of our patients are chronically ill, and we know that chronic illness leads to anemia by various mechanisms. Acute illness also does. So the inflammatory mechanisms in the body really do tell the bone marrow, hey, we need to be doing other stuff rather than cranking out red blood cells. So that's one of the reasons why patients can be anemic. They're often in the setting of inflammation, specifically the systemic inflammation that we see in the ICU, a low level of hemolysis that we don't necessarily detect, but probably is there for many of our patients and can be another driver of anemia. And then, of course, there's bleeding. About 10 to 15% of critically ill patients will have some level of clinically relevant bleeding. And so all of these things can combine to create very high rates of anemia in the ICU.
You know, Jen, you've already mentioned a common refrain in the pediatric ICU is matching oxygen delivery to oxygen consumption. And you've also overviewed for us that so many of our patients develop anemia for a number of reasons while they're critically ill. I feel like the physiology here is quite fascinating, and it's core to our instruction in Pediatric Critical Care Fellowship and the work that we do at the bedside every day. Will you remind us, what are the physiologic compensatory mechanisms that allow patients to maintain adequate oxygen delivery in the context of anemia?
Yeah, absolutely. So a lot of it has to do with maintaining cardiac output, right? So, tachycardia, particularly for kids who can't augment their stroke volume quite as well as adults, tachycardia is going to be one of your major mechanisms. But there are other mechanisms that, as we're learning more about the fact that red blood cells aren't just inert bags of hemoglobin that carry oxygen, that they actually do interact with the endothelial microenvironment of your blood cells and your capillaries and change blood flow via nitric oxide and other mechanisms in ways that promote greater blood flow to areas that are in oxygen debt at the organ and tissue level. And so it's a challenge because much of what we measures the global sense of oxygen consumption or whether or not you've matched oxygen delivery to oxygen demand. But it's entirely likely that what's actually important is more at that individual tissue level in the individual capillary beds. And that's been much more challenging to measure, but is likely one of the ways that the body does adapt to anemia and oxygen debt that may result from it.
It's a really interesting point. You think about the child who has worsening multi-organ function, but their pulses seem fine. Perhaps even their capillary refill is fine. And there might be some aspect of the microcirculation that we just haven't figured out a way to measure yet. And that just brings back the perspective of needing to evaluate the whole patient to make sure we're supporting them appropriately during the critical illness. You mentioned the fundamentals here. If a patient is anemic and has oxygen delivery debt, the first thing they're going to try to do is increase their cardiac output, either primarily through increasing heart rate or increasing stroke volume. In our youngest kids, they can't necessarily increase their stroke volume very much. So heart rate is the main player here. There's also this aspect of the oxygen extraction ratio. Will you tell us more about that?
Yes, the oxygen extraction ratio. I should ask Kailey to weigh in here. I know she's been looking into this in preparation for this episode, but it is a really fascinating piece of biology that we don't often talk about. Kailey, I don't know if you want to jump in here.
Sure. This is one of the things I like to talk to the residents about a lot too, because I feel like peds boards will always ask about what shifts the curve to the left or the right, that oxygen dissociation curve. And so I think one of the things that the body does that we don't talk about a lot is it increases the 2,3-DPG, which is that protein on that red blood cell, and shifts that curve to the right to enable offloading of the oxygen from the hemoglobin molecules. And then also you have the Haldane effect and the Bohr effect. So the Haldane effect is when oxygen is on the hemoglobin, it decreases the hemoglobin's affinity for carbon dioxide and increases the affinity for grabbing onto other oxygen molecules. And then the Bohr effect is kind of the opposite, where in the setting of acidosis or increased H ions or CO2, it then reduces the hemoglobin oxygen binding affinity. So your body is always trying to find that homeostasis of getting oxygen where it needs to go, getting CO2 out of the body in the different physiologic states that it finds itself in.
Absolutely. That's one of the examples of why I think, the human body is just infinitely smarter than we will ever be in so many different ways.
No, that's wonderful. You've overviewed for us almost the mystery of hemoglobin, how it has an affinity to acquire oxygen in the lungs and then deliver oxygen in the peripheral tissues. And even though we haven't said explicitly yet, but as oxygen consumption increases, those red cells will even deliver an increased percentage of their oxygen molecules at the tissue. And that's one of the earlier compensatory mechanisms for shock. It turns out that reaches a limit, just like anything else in physiology. And the red cell can only release a proportion of its bound oxygen. If you get much lower than 50%, you're going to have worsening organ dysfunction and shock. So we just round off all of these core mechanisms that perhaps we'll find on high stakes exams in the future.
Absolutely.
Jen, if you could talk about different relevant studies that have gone into the guidelines that we do have for PRBC transfusion practices in critical care.
Yeah, absolutely. So probably the one study that any trainee of pediatric critical care should know and should read in the area of red blood cell transfusion is the TRIPICU study. So the TRIPICU study was published in 2007 in the New England Journal of Medicine. Jacques Lacroix was the lead author. This was one of the first studies of the Palisi network, and it's a BloodNet subgroup. And it really, at its time, was one of the largest randomized controlled trials in our field. Randomized nearly 800 kids to a hemoglobin threshold of less than 7 versus greater than 9, with the primary outcome of the development of newer progressive multiple organ dysfunction. And the way they set up the trial is that they a priori set a threshold to determine non-inferiority, so that at the end of the day, the trial didn't just fail to detect a difference between the two groups, but they failed to detect a difference between the two groups with a confidence interval that allowed them to interpret their findings as the lower hemoglobin threshold being non-inferior to the higher hemoglobin threshold. And that's an important methodologic note to that study. But it's the study that really did ask that fundamental question of, can we allow permissive anemia in the ICU? There were a number of different subgroups that were included in the trial and some subgroup analyses that flowed from that. And that really was that landmark trial. There were a few other subsequent trials by Jill Chillette at the University of Rochester, specific to the cardiac population, to ask and answer similar questions. Can we allow a little bit more permissive anemia in patients who are undergoing cardiac surgery, including those with single ventricle physiology and cyanotic congenital heart disease? Those thresholds, of course, are different, but still a similar conclusion that it seems in the studies that we have thus far that we don't have significantly better outcomes by transfusing to a higher hemoglobin threshold. And those largely are what guided the guidelines that were published in Pediatric Critical Care Medicine in 2018, the TAXI guidelines. We love our acronyms, right? So TAXI stood for Transfusion Anemia Expertise Initiative. And that was a group that formed, again, out of the BloodNet subgroup of the Pediatric Acute Lung Injury and Sepsis Investigators, or Palisi network. that really took about 3 years after a structured literature search and consensus conference process to devise a set of recommendations to guide red blood cell transfusion in critically ill children. And Kailey knows that I can't talk about guidelines in our field without talking about the limitations of the guidelines in our fields. And she knows, of course, being one of my fellows, that my recommendation to all trainees is when these guideline documents come out or when you hear about one, do not just read the bullet point executive summary of what the guidelines are, because the real pearls are those rationale statements. It's the literature search that guided the recommendations. And in our field, it's often the lack of literature that led to the vast majority of the recommendations actually being consensus opinion. And so I always challenge our trainees to look at the literature yourself. Would you have come up with the same recommendations that the expert panel did? And I find it to be quite an interesting exercise. The taxi guidelines were one where we did at least have a moderate certainty of evidence based on the TRIPICU trial, but nothing more than moderate. And still, for many of the subgroups, we were left with low certainty of evidence to guide most of those recommendations.
Your suggestion that we go to the literature ourselves and really feel free to read those is well taken. But I have to ask, so you talk about the 2007 TRIPICU study. Do you remember the hemoglobin thresholds they used in their subgroups?
In the TRIPICU study, the thresholds were the same across the entire study.
Okay.
And so the subgroup analyses were planned subgroup analyses based on diagnosis. And so there was a subgroup analysis for children with sepsis or septic shock. There's a caveat there. There were subgroup analyses for brain injury, for respiratory failure. There were various different subgroup analyses based on diagnoses. I had to go back and look. But the thresholds were the same within the TRIPICU study. The studies where the thresholds were different were the congenital heart disease studies.
Got it.
Where I believe that the study for children with single ventricle or cyanotic congenital heart disease looked at 9 versus 11. Mm-hmm. And then those with two ventricle repair or non-cyanotic looked at 7 versus 9.
Nice. And what hemoglobin were they looking at in TRIPICU?
TRIPICU was 7 versus 9.5.
So I will say kudos to the authors for designing and carrying out the TRIPICU study. I will know that when a kid is getting sicker in front of me, I want to be able to control everything that I can. And we've already talked about how core to oxygen delivery is the hemoglobin concentration. And if that's just something, I see an abnormal number, I feel like there's a theoretical rationale that if I improve that number, I can help that kid in front of me. But the benefit of science is that we can test it. And we don't have to rely on these whims and just physiologic underpinnings. You've overviewed for us many of these key studies. And as we kind of reflect on where we're at in 2026, what does the guidelines say that should be our baseline threshold for hemoglobin in the critically ill child? Let's not dive into the nuanced circumstances quite yet. What is the general recommendation?
Yeah, so the general recommendation is that for a critically ill child who is hemodynamically stabilized, so this isn't the child who is in acute shock that you're still resuscitating and you're continuing to escalate vasoactive support as an example. So the hemodynamically stabilized critically ill child, that you should refrain from routinely giving a red blood cell transfusion if the hemoglobin is greater than 7. That in general, unless there's a reason to transfuse, you should not transfuse if the hemoglobin is greater than 7. Where the threshold is when you should transfuse within the most recent guidelines, that window between 5 and 7, the recommendation is clinical judgment. And that is because there really aren't any evidence out there to say, well, what is the absolute minimum? Because the way the studies were designed looked at 7 versus higher and hasn't really dropped that number much lower. We do know from studies largely in Africa that there is an inflection point of mortality when the hemoglobin goes below 5. And so that's one of the reasons why that area of clinical judgment is between 5 and 7. And if the hemoglobin is less than 5 in the ICU, in general, the recommendation is going to transfuse, although there are some efforts in the severe iron deficiency anemia world outside of the ICU that are starting to question even that.
Oh, wow. Are there clinical scenarios, I guess this is a question for all three of you, where you let that hemoglobin ride down to 5 in a PICU patient? So let's say they have like at least respiratory failure, right? Like that they're not just waiting on discharge.
I feel like all of this is going to depend on their big clinical picture. Mm-hmm. I am not somebody who in the high 6s pulls the trigger on transfusions, particularly if, let's say, respiratory failure, a broncholytic on BiPAP, and they're fluid overloaded. And I think that my plan that day is going to be to diurese them. If they're hemodynamically stable and in the high 6s, I think about it a little bit more judiciously. But I don't know if there's ever a clinical scenario outside of if their parents have religious views against transfusions that I would ever not transfuse less than like 6.
Mm-hmm. Mm-hmm. You're like, okay, let's try and do less, or like just focus our therapy a little here.
Mm-hmm.
Yep.
I think the point about fluid overload is really key to consider. In thinking about various patients where I might be more comfortable in the lower threshold, I think Jen already mentioned the iron deficiency piece, and I certainly would rely on consultation from hematology there, but that is a patient population where we sometimes wouldn't transfuse red cells as early. Jen, we'll be happy to hear your comments on that.
Yeah, that's something that has shifted relatively recently. It used to be if the hemoglobin was less than 5 in the setting of severe iron deficiency anemia, even in a child who is otherwise hemodynamically stable, the default used to be admit to the PICU and transfuse. And now that has shifted in many places, including our own, to IV iron and monitor for patients that don't have significant symptoms from that degree of anemia. And we're finding that the outcomes are actually pretty good with that approach. And so the reflexive, we must transfuse if the hemoglobin is less than 5 in that setting really has been called into question. And we similarly, I think our absolute threshold has drifted down to 3 for severe iron deficiency anemia for transfusing, although it's common between 3 and 5 that we're transfusing because there are some symptoms. But we don't necessarily try to transfuse all the way up to 7. It would be 1 small volume aliquot IV iron, and if the symptoms have resolved, we are transfusing less even when we do transfuse.
That's fascinating. I mean, transfusions in these kids with severe iron deficiency anemia are fraught with issues, right? Mm-hmm. There's a reason we put them in the PICU to do these things. I mean, their risk of fluid overload and heart failure is not insignificant.
Mm-hmm.
It also makes me wonder, is it just when you think about the conservative management strategy, is it also about not exposing them to blood? And do you want to talk about those benefits a little bit?
Sure. Just like everything else that we do, blood isn't benign. There's nothing that we do that isn't without some side effects or potential complications. There are the things that we often hear about and teach our trainees. And Kailey, I'm sure you could rattle off the known complications of blood transfusion, the things that we tend to talk about in our consent forms and in our lectures.
I mean, I feel like there's always the fevers that we see most commonly. Then there's TACO, transfusion-associated cardiac overload, and then TRALI, transfusion-related acute lung injury, which I always have a hard time with TRALI with our patients that are getting worse and they need blood, and then their lungs take a hit. Was it their pneumonia fluffing out? Is it a TRALI? And part of the diagnosis of TRALI is that it's not from another source, and I feel like TRALI in the PICU is probably underdiagnosed because they come in for a reason and then need blood. But I feel like red blood cell transfusion, like you said, Alice, they're not benign.
Yeah, Kailey brought up a really good point there. And that is when you look at the definition for transfusion-related acute lung injury, part of the definition is that you don't have another reason for lung injury. And that almost never happens in the ICU population. And yet there are fairly compelling preclinical data that would suggest that not only can red cell transfusion impact lung function, but that there may actually be a synergistic effect with mechanical ventilation, whereby you may have even more adverse effects related to red cell transfusion in patients who are already at risk because of mechanical ventilation. The tricky part is how to document that in our patients, because there are so many things happening at once that getting at that causality in actual patients is really, really hard. Something that I think about. And it's also something that I often think about when people talk about giving red cell transfusions for patients with severe ARDS because they have severe lung dysfunction. And on the one hand, it makes sense, right? Because we're thinking back to that math that we already talked about, that if my lungs are so bad that I'm tolerating a lower oxygen saturation, so I'm tolerating an oxygen saturation in the high 80s, well, I should give a red blood cell transfusion so I can maintain my oxygen content of the blood and oxygen delivery. But if that red cell transfusion then potentially worsens the lung disease and actually makes the underlying problem worse, then maybe you haven't done the right thing. I don't know exactly which one is right. And I think that's one area that's really, really important for future investigation.
I will say, reflecting on our conversation thus far, we talked a lot about the fundamental physiology of oxygen delivery. And then we talked about, how pointer to that is the hemoglobin concentration. But then we picked at it and we talked about how, sick kids can tolerate low hemoglobin levels. And then we talked about potentially some of the harms of giving red cell transfusion. But then we think about, what do we use to decide we're going to give a red cell transfusion? Commonly, we don't talk about oxygen delivery capacity or what's their lactate level or potentially other biomarkers. We use the hemoglobin concentration. Is there any kind of evidence for a non-hemoglobin concentration centric model to guide transfusion? Any other alternatives?
That is a fantastic question. And I think that's one of the limitations right now is that our evidence-based, not just in kids, but in kids and adults, is based on hemoglobin thresholds. And so that's what we have right now, though it probably, for all of the reasons we've just been talking about, is not the best way to decide when to transfuse someone. The challenge is we haven't yet found the magic bullet of the combination of factors to use. And at some point, that mix or combination of factors gets to be really complicated and potentially too complicated for one human at the bedside to figure out on our own. And that's where I do think there may be a future path for machine learning guided decision support. You have all of these different surrogate markers of oxygen delivery, oxygen consumption, potential oxygen debt, hemoglobin fluid balance, because I think that the reason for anemia probably matters. All of these things are really hard to sort through at the bedside, but could machine learning help us there? And that's actually one of the things that we're working on. That's one of the things that we have an ongoing observational trial to test the hypothesis that we can identify those factors and using machine learning, identify patients for whom red cell transfusion may be beneficial versus harmful. And I should backtrack and say not just patients, but when the transfusion may be beneficial, because that's the other piece too, that as we know, as intensivists at the bedside, trajectory is really important. And so many of our studies have really not been able to fully account for that trajectory, right? Two patients might come into the ICU and have very same level of shock, same hemoglobin, maybe even same underlying characteristics. But if one gets better and the other one continues to get worse, those really actually are different patients. But we often don't capture that in our studies. And so I think that the reality is when you ask people what you should think about when giving a transfusion, we all talk about, well, not just the hemoglobin concentration, but also oxygen debt, oxygen delivery, and all of these other factors, including trajectory. But that's really hard to operationalize at the bedside. And when you actually look at what predicts who is transfused in the ICU, it's hemoglobin, because that's what we actually use.
Mm-hmm.
I will say, before I be quiet and give the floor back, it seems like an application is deciding to transfuse a patient who's obviously not bleeding in front of you, but like majority of our patients, it's an incredibly nuanced decision. And we need to be very thoughtful. And a critique for my and our local practice, this may be the same for you guys, when are CBCs generally ordered and obtained? Between 2 and 4 a.m.? Who's making the decision to transfuse or not transfuse? that poor on-call physician or on-call frontline provider who is scrambling to reconcile all these labs at 4 and 5 o'clock in the morning. They're tired. They probably don't have much capacity to really lean in and make really nuanced clinical decisions when kids are falling apart and getting sick right in front of them. I think it's just a critique where we should probably think about transfusion like in a setting that allows for this nuanced conversation. And I'm a little skeptical that 5 o'clock in the morning is the best time to do that.
I feel like that's always when I catch the transfusions being ordered. It's, the labs came back, the resident reflexively ordered it, and it's like, but they're okay. Or like, we're going to diurese them later, like I had said earlier. Or they're hemodynamically unchanged and it dropped like to 6.9. I feel like that's always like the time where, as the fellow, you're also running around the hospital and going to, our rapid responses and other things, but they're so reflexively ordered because of that number. And actually it probably takes a lot more of a nuanced thought process. But I agree, we get these labs and we make these decisions at probably not our best time.
The other piece of this too is that it's not just the intensivists making these decisions. There are other consultants who are weighing in as well, and everybody is relying on their own evidence base or set of guidelines or thought processes around transfusion. And so you're talking about nuanced conversations now within an interdisciplinary team that does also increase the complexity of this decision-making sometimes.
Oh, yeah. Wait, Jed, is your prospective study looking at patient data? Are you looking at vital sign data and like telemetry too, or just lab markers?
We are looking at vital sign data, lab markers, and quite a few clinical data elements right now. Yep. Much of the focus is on hemodynamic measures. We also are looking at some biomarkers of immune function and inflammation. The piece that we haven't talked about in terms of potential side effects of transfusion are immune modulatory effects that we know happen in the laboratory, but is also challenging to detect in our patients. And so the idea being, is there potentially something about the underlying inflammatory state of the patient that if you add an additional potentially immunomodulatory insult on top of that, that changes the risk-benefit balance? It's tricky because if that transfusion actually is helpful and helps to alleviate shock, which is one of the primary drivers of the inflammation to begin with, then your net balance might be beneficial. But if the patient isn't in shock, or if the transfusion isn't efficacious to fix the shock or improve the shock, and the patient is acutely at risk because of their underlying inflammatory state, well, then that might tip the balance the other way. So it adds another layer of potential complexity.
Does the storage of PRBCs affect their immune modulatory effect?
That's so interesting, Kailey. So there was a lengthy body of work that really was trying to get at this notion of the red blood cell storage lesion. This idea that, and it makes sense, right? A bag of blood sits on the shelf for anywhere between 35 and 42 days, depending on what the red cells are stored in. And there are known biochemical changes that happen to the red blood cells during storage. And those changes likely have some impact on the immunomodulatory potential and potentially on the ability of those red blood cells to manipulate the circulation, get around to where they need to go, and offload oxygen as they need to. What is really interesting about that is the ABC-PICU trial and other studies that when you actually ask the question in an RCT, we really haven't found a difference in outcomes when you randomize patients to receiving fresh versus standard issue, generally older or longer stored red blood cells. And so that begs the question, well, maybe those things that we saw in the laboratory and in preclinical models just aren't enough to be clinically relevant in people. Absolutely, maybe part of this. Or it may be part of a similar limitation that we have to all of our clinical trials when you lump a bunch of patients together and you have some patients for whom maybe this matters, other patients for whom, well, maybe they weren't at very high risk. And you look at the total net effect, and maybe it's a signal to noise problem. It's really hard to tell at this point. Right now, we can't definitively say that there's evidence that fresh blood is better. But I don't know that the question has been definitively answered for all time. I think there is something worthwhile to be thinking about. Are there potentially subsets of patients that may be at higher risk of the effects of stored blood?
Now, I will say a theme on many of our recordings is this desire to enrich the patient population being studied to allow for individualization or personalization of care. Almost certainly is the future of every type of pathology we take care of the PICU.
So Kailey, I appreciated your comment about those brave residents just ordering that blood, 3 a.m. They're staying awake.
And then Kailey going, Dr. Muszynski's on service. What are you doing?
Stop it. Like,
although actually,
no, we appreciate you.
Yeah. I tend to transfuse more than some of my other colleagues, actually, in the setting of shock.
That's surprising. Oh, okay. I like to hear that because you're the expert. When residents order their first blood, in the NICU especially, they start to hit these keywords like leukoreduced, washed, irradiated. What are we looking at here? Like, what is that?
So this really gets into what are all the things that happen in the pipeline from when someone donates blood to when that blood is transfused. There's actually a fair bit of processing that happens. And in reality, that processing is different from unit to unit and sometimes from place to place. That's another thing that actually makes all of this even more complicated because very few of our studies have taken that into account when we think about the risk and benefit of transfusion. And so I think it's worthwhile at least, understanding what some of those things are. So leukoreduced. So basically, when we think about some of those immunomodulatory effects of red blood cell transfusions, at least some of those probably come from the residual white blood cells that are still left behind when that bag of blood is processed. And so the vast majority of red blood cell products that are transfused in the US now are pre-storage leukoreduced, which means they go through a filter to remove the majority of white blood cells. They still don't remove all of them, but the vast majority get removed before that bag is stored. Now, irradiated red blood cells, what that does is that actually goes after those remainder white blood cells. And so if you have a patient for whom giving a transfusion that includes any white blood cells residual would be potentially dangerous. So a patient who has a severe congenital immune deficiency, as an example, those are the patients that would receive irradiated red blood cells. Washed red blood cells are something that are different and much less commonly used. So washed red blood cells. So the idea there is, we mentioned briefly some of the things that happen biochemically to red blood cells as they're sitting in a bag of blood. So what are some of those things? The red blood cell will start to shed portions of the cell membrane and undergo little bits of essentially hemolysis, right? Now, there's a limit to that, and that's actually one of the ways that blood products are regulated is by how much hemolysis happens during the course of storage, but there is just a little bit. At the end of the day, red blood cell stored products will have a higher potassium, potentially, and these bioactive lipids and microvesicles or extracellular vesicles that are coming from the red cell membrane. And there's a thought that washing will remove those and improve the safety profile of the red blood cell unit. For most cases, that's really not necessary, and there actually are off effects to the washing as well. And so it's a very small use case for washed red blood cells, and largely that's going to be driven by the blood bank folks who will guide those decisions.
Nice. And then our last question before we move on to our cases is, I remember some of my co-fellows would say, you talk about oxygen carrying capacity, you talk about putting more red blood cells in, but the delivery is not the same from transfused blood as it is in the patient's own blood. Is that true?
Yeah, it probably is true, right? And I do tell my trainees, one of the reasons why blood conservation efforts are so important is that your own blood is going to be way better than anything I give you from someone else that's been sitting in a bag. Now, the extent to which that is true and what the actual effects of that are has been a little bit tricky to pin down. And so the things that we see that happen to those stored red blood cells in preclinical models where we see a lower ability to offload oxygen where you would need it, the immunomodulatory effects, et cetera, have been a little bit trickier to pin down and really identify in the patients. And one of the hypotheses out there is perhaps the red blood cells, as they enter the in vivo environment in the body, they kind of are rejuvenated a little bit, and you have access to the nitric oxide and the 2,3-DPG that had been depleted in the bag. And so maybe that's part of it. Or maybe it comes down to the fact that it's been really hard to tease this out in our studies that have heterogeneous patient populations, again, really need to pin down who are those patients who would be at greatest risk, who needs the transfusion to begin with. Because if you didn't need the transfusion to begin with and the transfusion didn't work as well, then you're not going to see an off effect. And so it's really tricky to actually see that at the bedside, even though there is still pretty compelling evidence in the preclinical space about those potential concerns. But just like anything else, your own is going to be better than somebody else's, right? That's probably true.
I feel like more and more lately when getting blood consent, I've had families ask, can I donate to my child? What do you say to them about the process of why they can't?
The answer is they can, but the process takes time. And that's usually the rate limiting step. And so you have to have a mechanism for that set up wherever you are. And even if it's a directed donor, that blood product still has to undergo testing. So all blood products will undergo testing for bloodborne pathogens, as an example. And that process generally takes a few days. And so what I would often tell families is, I'm happy to give you information about our directed donor program, but I need you to understand that process takes a couple of days. And I don't think we can wait that long for this transfusion. But any patient who's in the ICU is at risk for needing another one. And so that may help to have product available for a subsequent transfusion.
And thank you for listening to this episode of Peds Crit. Please remember that all content during this episode is intended for informational and educational purposes only. It should not be used as a replacement for medical advice. It's also worth noting that the views expressed during this episode by me, Zach, and our guests are our own and do not reflect the official position of our institutions. If you have any comments, suggestions, or feedback, you can email us at pedscritpodcast@gmail.com. If you want to help support the production of Peds Crit, you can find us on Venmo and Patreon. We've also had some light merch made in the form of Peds Crit laptop stickers, and if you include a mailing address with any contribution, we would be so excited to send you one. Thank you again for listening.
To say the names again, Jennifer Muszynski. Didn't sound right.
Muszynski?
Muszynski. So mu like a
Muszynski.
cow, shin like your leg, and ski down a hill.
Wow, that's wonderful.
My younger brother came up with that when I got married, and nobody in our family could say my husband's last name.
Oh, yeah. That's funny. There was like a pre-wedding.
Yeah.